Thank you so much, Brendan. Thanks, everyone, for joining us for today's webinar on addressing violence through behavioral health and behavioral safety teams, brought to you by the AHA's Physician Leadership Forum. To present today's session, we're very pleased to have with us representatives from both Southern New Hampshire Health and Cincinnati Children's. Joining us from Southern New Hampshire are Michael Gallagher, Director of Behavioral Health Services, and his colleagues Michelle Gardner and Lisa McCarthy, clinical managers in the Inpatient Behavioral Health Unit. And they'll share with you the work they've been doing on behavioral rapid response teams at Southern New Hampshire. Then we'll get a chance to hear from Adam Hill, Assistant Vice President at Cincinnati Children's, who will talk about the work that they're doing with their behavioral health safety teams. So without further ado, since we have a lot of great presentation to come, I'm going to turn the call over to Michael Gallagher and the team at Southern New Hampshire Health. All right, your slides should be coming up, Michael, and then take it away.
Okay, thank you for the introduction. Here is the Southern New Hampshire's presentation on our Behavioral Rapid Response Team. While our presentation today is focused on our Behavioral Rapid Response Team, we want to emphasize that this model can be applied to all clinical settings, not just to the behavioral health setting. Our discussion today, we want to explore and discuss the history of the Behavioral Rapid Response Team, also known as BERT, the roles of the BERT members, the criteria for the implementation of a BERT, and BERT education and training. Southern New Hampshire Medical Center is a 188-bed acute care facility in Nashua, New Hampshire, that includes a 30-bed voluntary inpatient behavioral health unit. Our medical staff include nearly 500 primary and specialty care providers serving more than 100,000 patients each year in 32 towns within Southern New Hampshire and northern Massachusetts borders. In 2003, the unit relocated from the main hospital to the West Campus, located a few miles away. Over the years, the size and number of beds of the unit have varied from 30 to 13 as a result of healthcare system changes. Today, the unit is an 18-bed voluntary adult psychiatric crisis stabilization unit. Our average stay is 7.5 days. The physical layout consists of 3 hallways on the same level. Staffing ratios are, on the day shift, there are 3 RNs, 2 BHAs, a recreational therapist, social workers, psychiatrists, and 2 security guards. On evening, there are 3 RNs, 2 BHAs, 2 security guards, and on night shift, there are 2 RNs, 2 behavioral health aides, and security. Our philosophy of care is to promote a safe, restraint, seclusion-free environment, consistently support respective behaviors by intervening early using negotiation skills and providing least restrictive interventions, and facilitate a team approach that relies on excellent communication skills and consistent use of managing of aggressive behaviors, also known as MOAB. Overall goal is to mitigate risk and improve safety using least instructive interventions by being proactive instead of reactive. Have you ever been involved in a restraint or a seclusion? Had to deal with an aggressive patient? Been the lead when dealing with an aggressive patient? Wish your intervention was more organized. Our challenges were there was a relocation of the unit, there was limited structure to manage patients' agitation and disruptive behaviors. Nursing staff felt unsafe. One important thing to note is that nursing staff are probably the most frequently victims of increasing violence in a hospital setting. Strategies were needed to assure staff safety and promote opportunities for early patient intervention when disruptive negative patient behaviors were identified. In our starting point in 2008, the inpatient behavioral health unit was 30 beds. We had 7 cases of restraint, 2 cases of locked door seclusion, and 9 minor assaults to staff. Embracing the Institute for Health Care Improvement encouraged the use of rapid response teams. The acting BHU director at that time, Donnelly Elliott, an RN, implemented Behavioral Rapid Response Team. In 2009, Donnelly published an article, Early Birth Safety Through Behavioral Rapid Response, and presented it in the New Orleans NBNQI conference. Our strategy was to address staff personal safety concerns, and the goals of BERT were to assure staff, patient, and visitor safety through early interventions, to provide an environment where least restrictive measures to lessen the use of restraints and seclusion. The other was to eliminate injuries and assaults to everybody involved in using these safety techniques. Our solution was the Behavioral Rapid Response Team. First thing we needed to do was figure out what a behavioral emergency was. So we decided that it would be any behavior which is escalating or potentially escalating with the potential harm to self, others, or property. Our goal was to initiate early interventions, promote safety, and prevent escalation in any given situation. Created the Behavioral Rapid Response Team is comprised of staff who bring critical assessment and intervention skills to emergency situation. This is achieved by utilization of a collaborative, interprofessional team approach to patient-centered care. Our results showed an increase in staff satisfaction, unit safety, patient satisfaction with the treatment team, and BERT interventions. We had 16 reported BERTs in 2017. Our other results showed that there was decrease in restraint and seclusion use. In August of 2016 was our last case of a restraint. Also a decrease in staffing requirements to do one-on-ones and a number of assaults and injury. Our success with this program on the inpatient unit has allowed us to introduce this model in other areas of the organization and lessened workplace violence. At this time, I'd like to turn this over to Michelle Gardner, our clinical manager.
Hi, thank you, Mike. I'm going to be talking about the structure of our behavioral rapid response team. So a few of our key points. All of the behavioral health staff are included as part of our BERT. A responsibility of our resource nurse at the beginning of the shift is to monitor and maintain safety for all of our patients, visitors, and staff. The BERT role responsibilities are based on individual staff strengths. It is important to note that roles may change depending on the situation. Our BERT also includes security and, when needed, engages environmental and food services. So where do we begin? Well, we begin our shift by assigning roles. The assignment is placed on a whiteboard, which we have located in our nursing station. These roles include a negotiation team, medication nurse, milieu management, patient safety, and a safety team. Ultimately, the goal of the BERT is de-escalation. The negotiator is most often the resource nurse. It is important that only one staff speaks to a patient at a time. It is critical for the negotiator to know their own strengths and limits and be comfortable when dealing with patients, since they are the first line of contact. They must demonstrate strong communication and negotiation skills while assessing physical and psychological needs. In addition, they may also offer or administer medications and obtain new medications orders if needed. They also help the patient transition back into the milieu when the BERT event is over. So our medication team. The medication nurse for the shift is assigned to the medication role. The responsibilities of the medication nurse at the start of shift is to review available medications for high-risk patients and to be proactive in medication administration. If medications are not available, the med nurse works with the providers who have PRN medications ordered, such as the agitation order set. The BHU agitation order set includes Zyprexa and Ativan, which can be given IM or PO, or Haldol, Cogentin, and Ativan, which can also be given as an IM or PO. They may also be administered on a schedule or PRN basis. Milieu management. So the milieu management role is often assigned to the behavioral health assistants. A milieu management shift responsibility of the BHAs are to complete therapeutic group activities and conducting continuous 15-minute safety checks. Therefore, they are the first to notice a change in a patient's behavior with potential for escalation. This is then communicated back to the resource nurse. In the event of a BERT, the BHAs who manage the milieu provide direction to move all others to a safer area. This then decreases the audience, hence decreasing stimuli to the agitated patient. While the BERT is taking place, the milieu manager distracts the other patients utilizing a bag which we have coloring, games, word searches, cards, fidgets, or other therapeutic activities. Patient safety. This role is assigned to either a BHA or an RN. This is very important since we are on a locked unit in preventing others from entering an unsafe environment, such as environmental services or the kitchen staff, and also communicating the crisis to oncoming staff. As most of us know, a code gray is a universal hospital page for violent or combative patients. A BERT is utilized as a code to make staff aware of a potential behavioral emergency. This is a step utilized to prevent advancing to a code gray. Safety teams. So all of our clinical staff must be MOAB trained. In addition, security completes rounding at the beginning of every shift. At that point, they touch base with the resource nurse. They will ask if there are any potential concerns on the unit. If there are, we come up with a plan to prevent any further escalations in the event of a BERT. Between 7 a.m. and 6 p.m., security walks throughout the West Campus. However, at 6 p.m., security is then posted on the BHU till 7 o'clock in the morning. One of the advantages of our unit is that we have cameras in all patient care areas. These can be monitored by BHU staff in the nursing station and also by security off the unit. It's a good tool to have since we have the ability to see in real time any event that is occurring, but we also have the ability to reflect back and use it as a teaching tool. The safety team also performs the physical interventions if needed, such as escorting a patient, placing a patient in seclusion or restraints. The post-BERT intervention. So we complete a shift huddle, which then goes over consistency with the patient, unit safety, and any kind of change in the treatment plan. We also talk about how the de-escalation techniques worked and debrief any other concerns that they may have. So I'm going to hand this over to Lisa McCarthy.
Thank you, Michelle. I'm going to go over the Behavioral Rapid Response Guidelines. As mentioned before, overall, our goal is to mitigate risk and improve safety using the least restrictive interventions by being proactive to keep the peace versus being reactive to a situation. Organizational expectations. Workplace violence is any act or threat of physical violence, harassment, intimidation, or other threatening, disruptive behavior that occurs at the work site. It ranges from threats and verbal abuse to physical assaults and even homicide. Violence may come from many sources: external parties such as visitors or criminals, and internal parties such as coworkers and patients. Southern New Hampshire Health System believes all employees are entitled to a safe, non-threatening work environment. This is a zero-tolerance, hospital-wide policy. PERT activation. We use IPASS as our communication model. When we give report, we indicate if a patient's illness severity is stable, a watcher, or unstable, and plan for what might happen. It is important to know individual patient status and a big picture of milieu interactions. All staff get report on all patients from the prior shift resource nurse. The shift handoff huddle is to communicate with the oncoming team for patient and unit safety, consistency in care, and follow through with the team treatment plan. Things may happen on the unit during report that the off-coming shift may need to pass on, such as behavioral discontrol. Education and training. We use online BERT education, which is completed during orientation and annually. This includes a PowerPoint presentation and a test with opportunity for the preceptor to clarify any questions for the new staff. It is also incorporated into the annual unit-specific simulation class. As mentioned before, BHU has cameras in patient care areas and can be utilized to look back for training purposes. Training. As unit educators, we review case scenarios over the prior year and create a patient. I then become the patient during the unannounced live mock code, which occur on every shift. Participants of the mock code are not allowed to tell other staff for optimal training purposes. The idea is that staff will utilize their skills and available resources to safely manage the behavioral crisis. As a team effort and to make it as realistic as possible, staff are expected to manage the situation as if it were real, which includes BHU staff, a psychiatrist, or medical internist, and security. During this time, Michelle oversees the mock code. When the mock code is over, it is debriefed as to what went right, what could have been better, and what were opportunities for improvement the next time staff are presented with a behavioral crisis. For example, last year during a mock code, it was identified that our psychiatric beds needed restraint rings at the foot of the bed, not just on the sides, so we had them added to the beds. Hopefully you have thought of opportunities for implementation at your hospital through our presentation. Thank you.
Thanks so much. And now we'll switch it over and have Adam tell us about the work at Cincinnati Children's.
Okay, thank you, and thank you to our partners there at Southern New Hampshire. Appreciate the lead in there on that great work. This is Adam Hill with Cincinnati Children's, and I appreciate everyone's time this afternoon, or at least for the next 20 to 30 minutes. And lastly, just a happy Mental Health Month to everyone for our month of May here. Let me work on. Okay, so here at Cincinnati Children's, we were established in 1883, and we are a large nonprofit, about 680 inpatient beds and about 30 residential psychiatry beds. We serve patients from all over the United States, and including about another 70 countries. We do have a core psychiatric and mental health service as part of our care continuum here. We have about 100 inpatient psychiatric beds for children and adolescents, but also those additional 30 beds. However, our time together. For the next 20 or 30 minutes, I'm going to talk about employee safety work that we launched here back in 2011 that really focused on employee safety outside of the psychiatric and mental health areas with our core medical staff who were caring for patients that had sometimes aggressive behaviors to manage through. As I shape up the information that I'm going to review with everyone in the next time together, there really are two key concepts or key thematic areas that I want to emphasize, which are reflected in these objectives. The first area is around the methods and the framework by which we approach this work of employee safety. And the second area is around the actual interventions and the clinical concepts that we adopted along the way. And so the first part of my presentation here will zero more in on those improvement science principles and reliability principles, which were our overarching guidance and pathways. And then the second half, I'll get into more details around the interventions such as risk identification and protective equipment and such. So one influential framework that really served as lending us some guiding principles and concepts for applications was related to the Institute for Healthcare Improvement's model of applying reliability principles. And as a reference there was part of the white paper series that the Institute for Healthcare Improvement put out around reliability. And the three key principles there are A, to prevent failure, B, is identify and mitigate those failures, intercede before harm is caused, or mitigate that in advance of the harm. And then C is redesign of the process, and that's really based on learning from critical failures that have or may have potentially occurred. The other overarching method that really is important, I think, for us explaining our journey has been the method of how we followed key improvement science principles. And so throughout this presentation, you'll see how we utilized tools such as key driver diagrams, various charts to understand our performance, in particular around employee harm events that occurred as a result of aggression from patients. How we went through plan, do, study, act cycles, and then, of course, those reliability principles. In a bit more detail, the improvement methodology. Here at Cincinnati Children's, we have the James M. Anderson Center for Health System Excellence, and the supports and the expertise in that area by offering such training such as intermediate improvement science series, which sets the course for the methodology. The improvement began formally in May of 2011. It's very important for all of our teams that we charter around quality improvement that we have frontline staff or direct care staff engaged. And in this particular work, we had our specialty resource unit, which is a float pool that responds to patient care needs all over the organization. Of course, I had mentioned earlier the Plan, Do, Study, Act methodology, which really helped us to learn and guide our interventions that we were considering. We utilized run charts as well as what you will see coming up, some days between charts, so that we can understand specifically our progress to our SMART aim. And then we also took careful attention to annotate and understand the impact of various interventions that we adopted and tested across sort of the chronological timeline of the initiative. So the charter, or the key responsibility of the team that came together, was to really define through a problem statement. And as I had referenced earlier, it was a focus on children and adolescents with behavioral, developmental, or psychiatric disorders in need of primarily medical care, but they would also present with aggression or aggressive behaviors or active violence when admitted into our medical surgical areas. and the frequency and severity of injuries to staff due to patient-related interactions were a concern for our clinical staff and our leadership at the organization. The project aim was to utilize quality improvement principles and interventions to reduce those staff injuries. The initial goal in 2011 was to reduce the overall number of injuries by 50% and increase the days between of what we call OSHA recordable injuries, which is a severity measure for us. So that would be those injuries of a more serious nature to greater than 200 days in between. And of course, we had an interdisciplinary team that was engaged as the chartering champions for this work. I will not go into great detail on this slide. However, folks are certainly welcome to take a look through the details, but this is an example of our key driver diagram, which really became our strategy map for how we're going to approach this improvement work. The SMART aim, the specific, measurable, attainable, relevant, and time-bound. Number one was to reduce staff injuries related to aggressive patient interactions from 2.5 per week to 1 or less for all patient areas excluding psychiatry. And that was work that began in 2011, and this key drivers for 2015. And the second measure there is to maintain OSHA recordable injuries at 0 for all patient interactions for those areas outside of psychiatry. The key driver column that you see there, that really reflects the how or the concepts that the team thought would be important to achieve those SMART aims. And the interventions there were more exactly or specifically those specific things that we went through plan, do, study, act cycles with. And we began to either adapt based on learning from testing of these interventions, or we adopted some of these interventions, and by those being green in nature, that reflects things that we did adopt along the way and begin to integrate into our normal system of clinical operations. And then we did abandon several things too, as we had great learning from failed tests of interventions that we thought may be a great idea, but part of the journey was understanding that some things were not feasible or reasonable. The last thing I'll point out on this particular slide, within those interventions, you see some parentheses that say LOR with some numbers behind them. Those are our levels of reliability. I'm not going to deep dive too much into the human factors or principles around levels of reliability, but we were thoughtful about those things which would be considered at a level 1, sometimes like training or education, to be more lower levels of reliability that really reflected just asking people to remember hard work and vigilance. And we did try to transform our system more closely to level 2 and 3 types of reliability, where we really began to standardize specific tools and interventions and help people be more successful as a routine part of their work to employ these safety interventions. This is a days between chart. So this tells the story of the results of this particular work. Specifically, these are those injuries that were more severe in nature, those that we called OSHA recordables, and these were for our medical inpatient units excluding psychiatry, and these were injuries associated with aggression from patients. So our baseline average, about every 36 days prior to the end of 2011, we had a more severe type of employee injury related to patient aggression. However, since 2012, we're now at an average of about 674 days in between having those type of employee harm incidents. So while we certainly look at the more severe types of harm, all of our injuries have gone down, but we've also increased our overall reporting of near misses or potential high-risk situations. So a little bit of backdrop on where this data comes from. We have a 24/7 call line for all of our employees, and if they should see any risk in the environment or encounter anything that they think could potentially cause risk or harm to themselves or to a patient, they are encouraged to call this phone line. However, if there are injuries that actually do occur, and that could be things like scratches or bites, hits, kicks, bumps, bruises, and anything more severe, we definitely have an expectation that those things are called in. So that's where the data is generated from, and our employee health department helps manage those particular aspects. So at this point, I'll start to transition a little bit more away from the overarching framework and the improvement methodologies, and transition a bit more into the clinical concepts and the clinical themes that were employed here. I always, when I have an opportunity to give these kind of presentations, I get asked a lot of questions about specifically what did you do, or tell me what the 3 or 4 interventions are. And I'm going to get into that a little bit, but I'll take a pause here to expound upon how important the journey was too. I believe strongly there was something about the culture that had to shape and shift by having a team that came together routinely to tackle this challenge and problem. So although I get asked a lot about specifically your interventions and specifically what did you do, I can't help but emphasize how important the reliability principles and having a charter team to follow the methods of quality improvement were to the success here. And I encourage anyone else who would be thinking about how to tackle this problem to also organize themselves around some journey that has to do with engaging all the staff involved versus just trying to go right after interventions and start implementing things, as each system, as we all understand, is designed a little differently. So with some of the specific interventions, and we did have several to shape up and change our system, one area here was timely identification of at-risk patients. We do have an electronic medical record at Cincinnati Children's, and so as part of our admission process, our nurses ask a basic screening question, a behavioral health risk screening question, about if the patient has or the family has any concerns about the patient having ever demonstrated or had any types of aggressive behaviors before, and in particular if they would possibly cause harm to anybody or if they have caused harm. With that being part of the standard prompt in the medical record, that took our levels of reliability up, so we standardized it and it was hardwired into the process. This also became very important from the reliability principles perspective, as this was our method to predict in advance where we thought we might have high-risk situations. The second intervention, there's the visible communication of risk. So once again, within our electronic medical record, once we did identify that a patient was at risk of potentially demonstrating some type of act of aggression or violence, we wanted to make sure that all staff who would possibly come into contact with that patient, or at least those that would be in the medical record or in the work environment, would have that knowledge. And therefore, we were able to create additional banners or prompts for individuals when they would open the medical record up to see that there is a safety risk to be considered for the care of that particular patient. And by clicking on that further, they can deep dive into understanding exactly what that would be. Early on, some of our learnings were that people were finding themselves in care delivery positions with patients and had no idea that the patient was actually at risk of causing harm to others or having a risk of aggression or violence. And so this, once again, enhanced those reliability factors and considered human factors and just increased the overall awareness for everyone. Third intervention listed here is we went through several different types of tests to ramp up the skill sets for our medical, surgical, or more critical care environment nurses, patient care assistants, and we weren't finding the success that we had hoped for with that. And we finally landed on that we needed to really have skilled individuals that had more core preparation in crisis, psychiatric mental health management, that understood the different types of pathology that come with mental illness or developmental disabilities, and in some of the more intensive cases, really put them at the bedside of those particular patients And we, of course, prepared them with some of the skill sets of patient care assistants, too. So we learned that we needed to have professionals available either rapidly or right at the bedside that really had a more core psychiatric and mental health background. And we believe that was one of our more important learnings early on in this journey. The fourth area here is the behavioral consultation team. Another example of really wanting to bring some expertise into the picture for those that have a better understanding around the potential acts of violence or aggression or the possible behaviors that patients might demonstrate as a symptom of their mental health challenges or their developmental disability. And so we did even hardwire into the process that, for example, if a patient screened positive in that initial risk screening in that first intervention, it would automatically alert somebody on the behavioral consultation team who could then within a couple hours be at the bedside and then conduct a more in-depth review and sort of case overview and behavioral treatment plan for a particular patient. Another valuable intervention there. The last one listed on this particular slide is the personal protective equipment. Much as we're familiar with other types of personal protective equipment to prevent transmission of bodily fluids or other things of that nature, we introduced behavioral protective equipment and made this available hospital-wide. It was something we were already familiar with within the psychiatric and behavioral health setting. And these are things like Kevlar sleeves, hats, Kevlar gloves, and arm pads. The hats would help prevent risk of harm from things like hair pulling if a patient had a history with that. Kevlar sleeves and gloves would help prevent severity of things like scratching or pinching or biting or grabbing. And in some cases, it would be just about having access to these particular pieces of protective equipment. And in some cases, depending on the frequency or intensity of the high-risk behavior of the patient, they may wear these at all times. So that really, we found, immediately started to have an impact on the severity. So some more serious scratches or bites that may have broken skin and really caused, some more significant physical harm to an employee. Those things, although they may still have happened, the severity of the injury was reduced significantly through using this type of protective equipment. There's a second phenomenon that happened with the use of this equipment that I would suggest we're still learning about, but there's something about having this equipment either in the environment or having it on yourself that increases your knowledge, your consideration for the risk in the environment altogether. And so just by having that type of prompt, consistent in the environment for the employees helps them be more thoughtful about the fact that they have to have considerations for the behavioral risk the patient may demonstrate also. Additional adopted interventions, and some of these are things that we are continuing to learn in the past 6 months to year. One was that we really thought that there were things we could do to hardwire into more day-to-day operations. So like many organizations, I'm sure, we have a nursing bed huddle that occurs within our institution. All units are represented at that bed huddle, and that happens 3 times a day. Although we look back and we think, wow, this was a rather simple intervention. Why didn't we think about this one earlier? Nonetheless, it's become a very powerful one, and that is to hardwire some scripting into those rounds to clearly make it a part of the call out. Does anyone have an employee safety risk in your areas, and in particular, do any of you have an employee safety risk patient that you feel like you may not have a plan or mitigation factors for? And this really helped us scratch the surface, so to say, a bit further and bring to the forefront patients that, for whatever reason, may have been missed through screening or other types of preventative systems that we had in place. So an intervention we're continuing to learn a good bit about, but certainly adopted, and we have found great outcomes with that. The second here is a critical review of all employee injuries that result from patient aggression. And the key principle here is that we made this standard, and we really made it a cause analysis type of approach, where we systematically wanted to understand when we had an event occur, or when we have an event occur, did the system operate like it was supposed to? So for example, did the patient have the screening, the behavioral risk screening completed? If they did, then what did we learn from that, and did we miss something? If some part of the system did not operate as we have designed it to, then we would look back and say, where was the breakdown, and why did that not occur as we would have anticipated for it to? The second really great opportunity with these cause analysis reviews is to trend and look at this data over time so we can have an appreciation for ongoing improvement work. I'm happy to share that most of these employee injuries we review now may not even be injuries, but they may be near misses or situations or events that could have potentially caused harm from the act of an aggressive patient that didn't reach that point, and we feel like there's great value to still be learned from those. So again, the key principles here is that we have standardized this, and we continue to hardwire this as a routine part of our safety work. The last adopted intervention that I'll share here is around how we're thinking about the system operation on a day-to-day basis. So methods by which we identify and manage patients identified as potential risk for aggression, and how we think about that collectively across the organization on a day-to-day basis, as well as our employees with that behavioral health expertise. And so this last presentation slide I share is where our innovation is at now. It's a bit raw in that we've not fully brought this to fruition, but I wanted to go ahead and share it. This is how we're trying to understand on a day-to-day basis. If you look to the left side of the slide, we're looking at how we can have a centralized patient list of all those patients that we think are at risk of possibly having aggression or presenting as harm to patients. And in real time, being able to look and see who are those patients and where are they located. And the other thing that this will do is help us look back over time so that we can understand over the past year or on a day-to-day basis about how many patients have we had in our service that we think present some type of risk for aggression or harm to employees, so that we can understand this population a little bit better, but also in real time, if we move to the right side of the slide, think about the employee resources that we may want to match with those particular patients. And so we began to think more clearly about exactly what the foundational training and education should be for all of our employees who may be matched in caring for one of these particular patients. We kind of have leveled them off from their competence through expertise, and also thinking about there are some patients that may be much higher risk than other patients for the pathology or the aggression that they may present. And so in real time, we want to match employees who have that type of expertise with their care delivery also. So this is a work in progress, but we're trying to be more thoughtful about how we operate on a day-to-day basis with more efficiencies, and then understanding where we have collectively pooled our resources. Initially, our focus was certainly on physical injury, and with having physical harm to our employees at about every 35 days, that seemed like where we wanted to go, was to really stop that physical harm and think about physical safety. However, we'd be remiss if we were not very thoughtful about the emotional and mental health and the overall employee well-being as their experience of caring for patients that in a lot of cases may not be patients that may be demonstrating symptoms that may be, from the employee's perspective, is not why they chose that particular field or area of work. So we have pulled together emotional support teams. We have a hospital-wide team. We've had some professionals come together, and this is run out of our employee health department and pastoral care and social work. And we have event support. So if we have events that maybe don't even cause harm to an employee, and we hope that we're actually doing more of these, but they're emotional, high emotion events, possibly there was a high intensity restraint or some act of violence that occurred. Nobody was harmed, but we understand that there's an emotional or mental fatigue that can happen with those experiences. And so we've set up group support. So we'll have pauses where we'll do connections within a few hours. We're beginning to implement Code Lavender or Code Compassions, where we think about more formal group support within 24 hours. And we even do further debriefing with employees. And all of this really out of the emotional and mental well-being for the employees involved. And then we certainly offer individual support also through our employee assistance program. Lastly, here I share a few references. Although all of these may not have informed specific slides that I had through the presentation, there were a couple here that I thought were innovative in nature and that I hoped individuals or leaders might find helpful as they think about rapid response teams or behavioral safety teams in their particular care environments.
Thank you so much, Adam, and I just want to let everyone know that we will be sharing these slides on our website, and we will send you an email to let you know once that's posted so you don't have to copy those down. But now we'd love to open the floor for questions for our presenters. So Brandon, if you could give the instructions.
Thank you. At this time, we will open the floor for questions. If you would like to ask a question, please dial the star key followed by the 1 key on your touch-tone phone now. Questions will be taken in the order in which they are received. If at any time you would like to remove yourself from the questioning queue, please dial star 2. Again, to ask a question, dial star 1 now. And we are currently holding for questions.
And you can also put questions in the chat box. And Adam, we have one for you that looks like you're typing back an answer now about whether the risk screen is standard within your EHR or did you have to build your own? Are you on mute, Adam?
I'm sorry, yes, I was typing the response there. So it is a standard screen, meaning that each patient experiences the same screening question by the nursing staff. However, it is internally developed, so it's not something that's that we found in any literature or any other best practice out there.
All right, well, and while we're waiting for folks to send in some additional questions, I had one for both teams about what, if you had to give the folks on the line sort of an initial piece of advice of where to get started, what's the most important thing you think you did when this project got underway? I'll start with you, Adam.
Yeah, great question, and I think I had made reference to this through the presentation, but I will emphasize this again. I really think you need an interdisciplinary team that really brings perspectives of all the professionals that are being expected or as a routine part of their work to manage violence and aggression that may come up. So I think one is really pulling that interdisciplinary team together, and secondly, I believe it's the leader's responsibility to set the course and to charter that and really serve as a facilitator and an active listener. And that leader, in my belief, should have some methodology or framework by which they're going to walk the team through to address the problem. So that's my response to that question.
Great, thanks. And the team from Southern New Hampshire, what's the sort of one thing you would say, this was the best thing we did or we started with?
We would actually agree with Adam. We think that the best thing that we did was to communicate with our clinical staff and to coordinate what we were going to do going forward with our hospital leaders. We were able to develop our plan and go forward with it.
Looks like we have another question for you guys at Southern New Hampshire. What was included specifically in the MOAB training, and was there a specific vendor that you used for that?
MOAB is actually a training technique that I believe is national. There's two parts to it. One of them, the first part, is an online part that we do, and that goes over techniques for de-escalation and safety. And the second part of MOAB talks about the physical component of it. So it's to be able to physically remove yourself from a situation safely. On top of that, if it escalates to the next level, how to safely manage a physically aggressive patient.
I do know that there are specific training facilities that train MOAB trainers that then can go on and certify other staff for the second part, which is more the hands-on of dealing with the aggressive patient.
Great. And I know you had said this, Michael, that your work is specifically at the behavioral health unit, but that it can be used, your program can be used at in any situation. Do you use it at Southern New Hampshire on the medical floors as well?
We've adopted some of the trying to bring in the early intervention and do education with staff in regards to, recognizing when somebody is becoming in the first areas of agitation and anxiety and try to prevent. I mean, the biggest thing that we try at Southern New Hampshire is early intervention is the key to a lot of these cases. And so, as Michelle mentioned, MOAB is across the board. Every employee in the hospital has to go through MOAB training. It's part of our annual training.
Mm-hmm. Looks like we also have a question about the behavioral consultation team and sort of idea of how many patients are being screened in and then need a consultation. What kind of numbers are you guys talking about?
Yeah, great question. So if we take out our psychiatric beds and we think about, let's just say roughly about 400 non-psychiatric beds, at any one time, those that are actively on the radar for concern or risk of harm, in the past year we're at about 6 per day. Now those are patients that carry over from day to day, but on average about 6 kids per day. Now if we look at how many screen in, that's part of the reason we're really looking at trying to centralize this. We've not captured that as well as we could or should have. But on average, if we look at just some consultations that may come through during the routine work year, there could be up to about 3 or 4 new ones a day on top of those 6 that are already on the radar.
All right. And Brandon, let me not forget to check to see if there are any questions on the phone line.
There are not any questions on the phone at this time, but as a reminder, if you do have a question and you'd like to ask it via the phone, it is *1.
Thanks. And we do have a few more in the chat box. And this, I think, for both of you, how are you addressing and I know you touched on this, Adam, a little bit, addressing the trauma experienced by the victims of violence and those exposed to the violence? And I know you mentioned a few, some of the work you're doing around employee wellness, but how do you both deal with that?
Well, I think that early debriefing is probably the key in getting the team to discuss, if there is a restraint, what went wrong, what could have gone different, what went positive, and, building on that process. I think that the other thing is we mentioned in our slide about milieu management, as far as the rest of the patients, I mean, they can be very much traumatized by seeing, this kind of event happening. So one of the key factors of this milieu management person is to get all the other patients away from this and try to protect, them from being traumatized from one of these events that happen.
I wanted to go back and comment about the hospital-wide implementation of the BERT. Michelle Gardner and myself did some brown bag lunches that we offered for security and all of the units at the main campus, and that was very well attended with especially good feedback from the security department. As well as that, when a situation occurs, we do a root cause analysis with everyone involved and see what actions come out of that. And for any new hires in the hospital, the nurses, Michelle goes to their orientation and talks about the behavioral rapid response team, the agitation order set, offers help from our unit.
Great. And Adam, do you have a response on the how you're addressing the trauma experienced by the victims of the violence? Anything else you wanted to add to what you had already mentioned?
Sure. So I think I'll answer that in twofold. One, I would suggest that I think we have a pretty robust process for those that come in primarily for psychiatric and mental health concerns. So we utilize screenings that are developed out of the ACEs studies. And with that, one, we have, a higher level of knowledge and sensitivity for all of our treating clinicians and employees on events that patients may have experienced that were traumatic in their life before being at the hospital. And then, of course, within our psychiatric and mental health areas, we have, then I would say, sort of evidence-informed approaches, things such as mindfulness and various individualized treatment planning around approaching trauma. However, in our non-psychiatric areas, we do have a screening question around potential trauma, but probably not something as robust as where we might like to see ourselves in the future.
One other add into that, in southern New Hampshire, part of our medical record is there is a symbol for any patients that do have history of violence in any of their stays, or when they're, evaluated in the emergency department. So, I mean, it's readily available for, those people logged into the system to see that we do have a potential person to act up. So, it's called the violence flag on the chart. Yes.
It looks like we have another question here about the huddle, the nursing bed huddle that basically passes on. So how is that managed, and who's involved in that?
So it's in person as the expectation, and so the bed huddles here with a number of units and such that we have, they're usually about 20 to 25 RNs that are really sitting elbow to elbow in a room representing all their areas. We do have some call in, and those would be our satellite locations, but those on site are expected to be there and attend. It's facilitated by a nursing manager who's responsible for operations across the institution on a shift-by-shift basis. However, we do have a physician safety officer who is present in those bed rounds, as well as often our hospital administrator will be present in those bed rounds too.
Great. So, and I think this goes back to both teams again, although probably more to southern New Hampshire. Are your rapid response teams the ones that would be using restraints, applying restraints if needed, or is that a different team that comes in to do that?
No, that would be our team that goes in to do that on the behavioral health unit itself. Downtown at the main campus, security is primarily the team that applies restraints.
It looks like we actually had a follow-up question on the issue of how you deal with the trauma of the violence on the providers. It's actually a good question. What is done for the trauma experienced by the patient? Do you have a protocol in place for that as well?
This is Adam here, and I'll speak to that in a proactive manner. Although I didn't share data on this because our focus was really more on the employee safety part. All this proactive screening in advance and then having behavioral consults done in advance are really about first just preventing those traumatic experiences from further occurring in the first place. And we've seen great strides in just the reduced number of restraints and a reduce in the number of outbursts or explosive types of behaviors, which helps us keep from re-traumatizing probably already traumatized patients. So the first thing I'll emphasize is I think we've done a lot in the way of just preventing more trauma for patients. However, in response to events when they occur, of course, we continue to debrief with patients on those. Most of these being acute hospitalizations, We're probably not diving too much further into other types of trauma work with patients, though.
Yeah. All right. Well, and it looks like I have a question about the number of members on the BERT team, although I believe that's in the slides, so Rhonda will make sure you get those. She's also asking about how behavioral health PPE is maintained.
And so our behavioral health PPE is laundered through the central laundering system. So we've set up a system and methods for that to go out to be laundered and returned.
Wonderful.
As we with sheets or scrubs or other things of that nature.
Okay. That makes sense. Well, I very much appreciate everyone's time to join us. It looks like we don't have any more questions in the queue. I do want to thank everyone for participating in today's webinar. Special thanks to our speakers for taking the time to share their great programs. As I've mentioned, we will have a copy of the slides and a recording available on our website, which is ahaphysicianforum.org. Those should be up the end of this week or so. Or the beginning of next week. Also wanted to point out that our next webinar is scheduled for June 8th. You can register on that same website. It's the Art and Science of Storytelling and the Impact on Leadership, which I think will be a very enjoyable session. So again, with that, big thanks to our speakers, and we're adjourned.
Okay, thank you.
Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. You may now disconnect your lines, log off the webinar, and have a great afternoon. Speakers, if you would please remain on the line.